Professor Fleischer is currently the Associate Section Head of the Section of Allergy and Immunology at Children's Hospital Colorado and an Associate Professor of Pediatrics at CHCO and the University of Colorado Denver School of Medicine. He is the co-director of the Food Challenge and Research Unit at the same place, and he will direct the new Allergy and Immunology Center at CHCO when it opens in February 2018. His primary clinical interest is food allergies, and he is the global principal investigator for the pivotal Phase 3 peanut epicutaneous immunotherapy and open-label extension trial that is being conducted at more than 30 sites across the world. And with that, without further ado, I would like to ask Professor Fleischer to present his lecture on food allergy prevention. Where are we and where do we need to go?
Thank you. Again, I'd like to thank the organizers for inviting me to speak today. I think this lecture will hopefully take upon what Gary just talked about, as well as some of the stuff that Mimi talked about, and hopefully put some of this together to kind of wrap up this meeting in a nice way. Again, these are my disclosures, which just have no bearing on the talk today. I think the important part is trying to identify what risk factors may play a role in food allergy. As Gary said too, if we can identify some of those, can we actually reduce those risk factors, modify those somehow, and actually prevent these allergies from actually occurring? And again, I think there's not going to be one factor that's going to cure everything. It's because this is multifactorial like it is with other diseases. But again, if we can identify some of those factors, then we may be able to better prevent it. But fixing microbiome over one thing or timing of introduction is not going to fix all the problem. But I like to look at these risk factors for food allergy divided into prenatal factors, perinatal factors, and postnatal factors. And again, there's a lot of things listed here. I'm not going to have time to go over all of these in any detail. We'll go through some select ones. Looking first at some genetic factors and family history, some of the things I talked about earlier. Country of birth, which is what Gary also showed in his migration from other countries to other countries, depending on where you were born. A maternal diet. Some of the perinatal factors, gut microbiota. I won't go into great detail because Mimi did a great job of talking about that, and we'll look at some postnatal factors, looking at primarily atopic dermatitis and the risk factors for food allergy based on that, timing of introduction, and then diversity of diet as was also discussed. First, some prenatal factors. Again, I talked about this in the talk earlier today at lunch. Again, I think that based on family history, based on the traditional risk factor criteria of high risk of having one parent or sibling having an allergic condition, increases your risk of allergy. Even if you have both parents that don't have allergy, you still have an increased risk. But with one or two parents, those numbers can increase to 20 to 40%, with two parents up to 60 to 80%. And I'll just take a poke at myself, looking at my family. This is my family. I was born in Boston, so this was our first game together at the Red Sox games in the summertime. So I have asthma, still on inhaled corticosteroids. I had allergy shots for my allergic rhinitis, and I had eczema as a child. Again, this is my wife, Veronica, who's from Venezuela, where the rates of allergy and food allergy especially are quite low compared to other countries. And she sometimes will admit she has seasonal allergies, sometimes not, because she wants to put the full blame on our kids having allergies based on my fault. Among other things she blames me for. And this is my youngest son, Mateo, who is 9. He's on allergy shots as well. He has asthma. He's on inhaled corticosteroids, and he has eczema. This is my son, soon to be a teenager, John, who also has asthma on inhaled steroids, and he's also on allergy shots. So is all risk equivalent? I'd say if you look at my family history, probably played a bigger role in our kids having allergies, but had my wife not married a gringo from the United States and married someone from Venezuela, would she have actually had kids that didn't have allergic disease? And I think that's an interesting question that we've talked about, and Gary talked about to some degree as well. What other things do we know about genetics with respect to looking just at peanut allergy? There have been several small studies looking at genetic risk factors. Jonathan Herhane, in a study about 20 years ago, looked at allergy in siblings or parents of kids that had food allergy, so their first-degree relatives. They found no skin test positive in patients for the parents, but they had 5 siblings that had a positive skin test. They challenged all those 5 patients with skin test positive results. 2 of them had negative food challenges. So they found a prevalence rate in siblings of about 7%. Again, a very small study, but likely showing some genetic factor with peanut. Scott Sisher looked at a twin study and found that in monozygotic twins, there was a higher concordance rate with peanut allergy in those siblings compared to dizygotic twins, again showing an increased risk of about 7 times if you have a monozygotic twin that has peanut allergy. And there's been one study looking at single nucleotide polymorphisms and a GWAS study. Interesting, both of those loci were found to associate with differential DNA methylation, which is a study that's an interesting study that came out of Australia looking at that may play a role in some factors in increasing allergy. But the bottom line with genetic data is we really have limited data from various lines of investigation suggesting genetics plays a role. I think it's one part, obviously, in a disease process, but it's not certainly the whole process. But we really have no studies that have shown consistency across populations. And Gary showed this study in a different degree, but we see this also, and not just from Asia to Australia, but we see it in the United States. So patients that have first-generation born children in the United States that came from India, other parts of Asia. Some of their patients, some of their children have some of the worst eczema and food allergy, and had they stayed in the country where they were born, those children may not have had allergies. Again, looking at this may play a role. In food allergy here, Asia has lower rates of eczema, more non-Westernized diet. We'll talk more about that compared to Australia. And again, if these patients had stayed in Australia, they may have had a lower risk of developing allergy. So children born in Australia to Asian-born mothers were more likely to have nut allergy based on data from the study, while children that were born in Asia and then subsequently migrated afterwards to Asia had less risk of developing nut allergy. So the timing of migration and where you're born seems to play a role, and again, we see that also in the United States. What about maternal avoidance diets during pregnancy? I'd say right now we don't feel that these play any significant roles to avoid major allergens in the mother's diet while she's pregnant. It really does not work and may actually may be harmful to the diets of those infants and the mother. So we really have no substantial evidence to say to avoid any foods at this time during pregnancy. Perinatal factors we'll look at again quickly because Mimi went over this to a large degree. Microbiome plays some role. Again, it's not the overbearing part, but it plays some role likely in the development of food allergy and the mode of infant delivery. So C-sections, you're not exposed to the vaginal flora. If you're born by C-section, there are actually studies now looking at doing vaginal seeding where they'll take a swab of the mother's vaginal cavity in patients that are born by C-section and seed that in the mouth and see if that affects the rate of allergy. Farming and animal exposure, health nuts, again in Australia, showed if you had a dog in the house that you may have decreased risk of developing egg allergy. Antibiotic exposure, again, the timing of that is either from the mom or soon after birth may play a role, but studies really haven't shown a consistent significant association with food allergy. And again, as Mimi talked about, there are differences between breastfeeding and bottle feeding in the development of the microbiome. Postnatal factors, like avoidance diets during breastfeeding and lactation, we don't recommend that moms avoid any major foods. It's not shown to have any role in decreasing the risk of allergy. There may be some debate with respect to the amount of peanut that's in a mother's diet, but again, the studies have not been consistent showing the amount is consistent with increasing or decreasing your risk of developing food allergy in those infants. So most academic studies do not recommend avoiding any foods in pregnancy or breastfeeding. But again, as I talked about this morning, breastfeeding is strongly recommended for multiple reasons. Breastfeeding has been shown for at least 4 to 6 months, exclusive breastfeeding, to possibly reduce the risk of atopic dermatitis within the first few years of life, reduce early onset wheezing that's likely associated with viral-induced wheezing, so may not really have an effect long-term on asthma, and may reduce the risk of cow's milk allergy. Really, the effects on allergic rhinitis or allergic diseases are not really known to have a clear effect at this time. But again, I think you have to be careful with these recommendations in breastfeeding because these recommendations are based on very limited evidence from what we call observational studies. You can't do randomized controlled trials ethically to breastfeed or not to breastfeed. So they're based on very small, non-randomized, not prospective studies, and we need more studies like that. But again, separating out breastfeeding versus not is going to be difficult to do. As far as, we talked about pre and probiotics, we really have no firm recommendations from any society to supplement at this time. And vitamin D, I know there's a study going on in Australia looking at supplementation with vitamin D or not. in the early born period and seeing whether that has an effect on allergy. So I'm looking forward to seeing those results as well. But right now, we have no clearly positive, again, as Mimi said, positive recommendation from scientific societies to support the use of either pre or probiotics on prevention of allergic disease, at least at this time. So the remainder, the bulk of what we'll look at is the timing of complementary foods and atopic dermatitis risk factors. A lot of the work I've done over the last 5-6 years has looked into the timing of introduction and how we may prevent based on that. Again, I think it's part of the issue and maybe part of solving the problem, but it's not going to be everything. So where did we come from? If this is based on the United States, before 2000 we really didn't have any advice on timing of when to introduce any major allergen, but in 2000, again based on some very limited data, unfortunately made recommendations from the American Academy of Pediatrics that you really should avoid all dairy until you're 1 year of age, all egg until you're 2 years old, and all peanuts, tree nuts, and fish until you're 3 years old. Again, these are based on very limited data, so much so that a short 8 years later, the AAP came back out and said there really are no convincing evidence that avoiding these foods will actually decrease the risk of developing food allergies. And then from 2010, 2014, we started to see more observational data before the more studies like LEAP and other ones that I'll talk about in a minute came out that if you actually delay the introduction of some of these major allergens, you may increase the risk of your developing allergy to them. And if you introduce them early, you may actually prevent them. So really the groundbreaking study that was done was the Learning Early About Peanut study, the LEAP trial. Again, the high risk here was defined a little differently than what we typically would use, as I talked about having a parent or sibling with first degree relative of having allergic disease. Here they said moderate to severe atopic dermatitis or egg allergy. While they chose egg allergy over milk allergy, we can talk about in another slide. But again, the criteria were a little bit different than what's talked about typically as high risk. These patients all underwent skin testing, so they were all screened with testing beforehand. They didn't randomize whether you needed to screen or not screen, but they decided to screen all patients. And anyone that had a skin test that was above 5 millimeters was presumed to be peanut allergic. They did not challenge those patients above that level, which is unfortunate because some of those probably would have passed and would have benefited from secondary prevention of their disease. The two groups were stratified based on a negative skin test or a positive skin test, which they defined as 1 to 4 millimeters. Again, most allergists would say above 3 millimeters. 3 millimeters or above would be positive, but they considered 1 to 2 millimeters positive in this group. And then again, they were randomized to either introduce peanut 2 grams 3 times a week for the first 5 years of life, or avoiding all peanut for the first 5 years of life. And then were challenged at age 5 years to see whether they had peanut allergy or not. And I don't question the quality of this data. I think this was a fantastic study. The ability that they're able to do this in such a large group is amazing, and we'll never be able to kind of replicate this, unfortunately, because there's such good data that we won't be able to randomize patients to avoid peanut or not in any of their trials, because no IRB would let us do those trials knowing that we're increasing the risk. In the skin test negative cohort, which was the biggest proportion of patients, so those had negative tests, so primary prevention, they were not sensitized yet, you can see an absolute risk reduction of about 12% and a number needed to treat of about 8.5. What was even more pronounced was in that sensitized group, the secondary prevention group that were already positive to peanut, ones that tolerated it when they first gave it to them. The absolute risk reduction was about 25% with a number needed to treat of 4, so a very dramatic effect in both cohorts, but more so in the ones that were already sensitized to peanut. There are some construction criticisms, which you can say is really with any trial. There was no placebo group or low-risk group comparisons, so we don't know what would have happened in the lower-risk group, that perhaps if they went on based on parental or sibling history. Again, I think the 5 millimeters was cut off somewhat arbitrarily, but they had to use something that's never been done to introduce and do challenges in infants really at this young of an age. We don't know whether we really need to do skin testing ahead of time. This was from one referral population in one country. And there was a high participation bias, over 96% retention, which is really dramatic in this population. And we'll talk about some of that when I talk about the role of a dietitian in this study towards the end of the talk and what roles they played. Again, high-risk criteria were based on arbitrarily from severe eczema and or egg allergy. And we don't know what the other doses and duration. This was 2 grams 3 times a week for 5 years. What if you introduced 4 grams once a week, or used 2 grams, or used more? Even more would have had some. Did you have to do it as long as well? But solely based on these guidelines, and I'll pick on myself and the US guidelines, because for over a 2-year process, in working with the NIAID, we came out with guidelines or addendum guidelines for the prevention of peanut allergy, solely again based on one study that wasn't even done in the US. And I'm not sure these guidelines are really simple enough or clear enough for the physicians that have to actually implement them. As I've said in other lectures around the world, we don't see, in the US, we don't see these patients at 2, 4, and 6 months of age. The people that really need to impart this information to the parents and things are going to be the primary care physicians. At least in the US, these physicians have maybe 10 to 15 minutes at 2, 4, and 6 months of age to talk about a number of other things, to suddenly try to talk about peanut with a family and introducing that when the anxiety around peanut allergy, especially in the US, is quite high. I'm not sure that they're able to do it, and I know they're not able to do it based on questionnaires and surveys we've done in the US, and I know there's been a survey actually done in Asia as well, that these guidelines aren't being easily implemented. I think we made it very complicated, and we will revise the guidelines from our society standpoint to make them hopefully much simpler for families to introduce. But again, based on the the LEAP study, they had 3 different risk criteria. So the highest risk of having eczema and/or egg allergy, to strongly consider evaluation first, which again is also, I think, problematic in some degree. Even we have over 5,000 allergists in the US. If we had to see many patients like this and get them skin tested and even challenged, the time, that window of opportunity from 4 to 11 months, we'd miss that window in a lot of actual challenges, because most academic centers will do infant challenges, but private practice groups are scared to do even just challenges in older patients. So doing them in young patients is less likely to happen in those practices, and the burden will be pushed on more academic centers. But they consider skin testing and or IgE testing. And again, as Gary talked about, we tried over the last 10 to 20 years to not encourage any screening tests with IgE tests, because we know families or physicians may get a whole food panel, and then you open up a whole door of, you may have a milk positive, an egg positive, and they may be avoiding those foods unnecessarily based on those tests. And then the age difference between the risk groups, 4 to 6 months for early introduction for peanut in the high-risk group. Again, I think there's a window of opportunity. It doesn't have to be at 4 to 6 months for this high-risk group, but that's what they put in the guidelines. The second risk criteria was for mild to moderate eczema, to introduce peanuts around 6 months. And the lowest risk is having no eczema or any food allergy, and introduce peanuts in an age appropriate in accordance with your family practices. Again, I think the easiest thing would have been to say, introduce it around 6 months for all age groups, instead of having physicians now have to talk about 3 different risk criteria with families. This was the algorithm that they came up for the highest risk population here. Again, they put peanut IgE testing in because a lot of there were primary care physicians who sat at the table when we had these discussions. There were dermatologists who were also at the table during these discussions, and they wanted to have some way of screening for allergy and not have to wait to send them to an allergist to get tested. Again, I think you open up some can of worms when you say you're going to screen test just for peanut, because while we may be able to do that in a test in the hospital, these food allergy panels are usually what we end up seeing, and some foods are taken out that they're already tolerating when they're positive. But if it was undetectable, you could introduce those at home or in the physician's office. If it was positive to any degree, then the recommendations were to be evaluated by an allergist with possibly skin testing and or challenge. I think it was interesting that they put in, you could introduce this in the provider's office. I don't know if any pediatricians or primary care doctors in the US that actually have the time and space to do an introduction in their office. They're seeing patients every 10, 15 minutes, and it's very difficult to ask them to try to do an introduction to an infant who may not want to actually eat it. The evaluation that's done in the allergist's office, we considered, more rightly, we felt that 0 to 2 millimeters was truly negative, and you could introduce those at home or in the office if parents are scared to do it. We increased the rate of the upper limit of the skin test from 5 millimeters to 7 millimeters. This is primarily essentially based on the Health Nuts data, which is based on patients that were 12 to 15 months, so an older age group, above 8 millimeters or above, over 95% chance of having a reaction to peanut based on the challenges they did in those infants. But with 3 to 7 millimeters, to do a food challenge, recommended supervised challenge, so these should be done in the allergist's office. And then there are many of us that have actually challenged patients even above 8 millimeters or higher, because even if there's a small chance that those infants could pass, I think most families that we've seen are willing to take the risk of not having peanut allergy and doing a challenge as long as it's done in a safe environment. What about the other foods that's been looked at? So the EAT trial, or the Inquiring About Tolerance study, looked at introducing 6 major allergens in a non-high risk group. So they weren't recruited for first sibling or a parent that had allergic disease. They weren't recruited for patients that had severe eczema or egg allergy based on LEAP. But they tried to introduce 6 major allergens, including dairy, egg, peanut, sesame, fish, and wheat, anywhere from 3 months up to 6 months of life, and then after 6 months of life while they were continuing breastfeeding. So this was, along with continuing breastfeeding, again, that was an important thing to maintain that they could actually do while introducing these foods. So general population, not excluded, included for high risk. The problem is trying to get infants to eat all these foods in the amount they wanted by 6 months of age was not easy to do. Milk and wheat, not surprisingly, milk was easier to get in on the forms that was introduced, and wheat was very successful, but that was introduced last. Peanut was only about 60%, fish about 60%, sesame 50%, and then egg 43%. They used tahini, so introducing a teaspoon of tahini into anyone, an adult, I don't think would want to eat a teaspoon of tahini directly, but that was what was chosen, and egg was kind of a mashed up, hard-boiled egg, which the consistency for a 3 to 4 month old is difficult to do. And we'll talk about how I would recommend introducing egg versus what they did here. But the overall compliance to get every single food in the amounts was only about 40%. What they found in the intention to treat analysis, they found no difference with peanut and egg. Per protocol analysis, however, they did find some effect for peanut and egg. But you can see the number needed to treat and the absolute risk reduction are significantly different than in the LEAP population. So the number needed to treat in LEAP was between 4 and 8. This was 40 for peanut. And again, this significant number that needed to be treated in this lower risk population to have an effect. But per protocol, they did find some effects. So what did it, in my opinion, really show us? There's likely no harm to introduce any major allergens. I think it's going to be hard to do in 3 to 4 month olds. It may not be necessary. You can introduce it with a wider range of months of age. And it didn't really have any effect on breastfeeding, which I think is important, especially with countries that abide strictly by the WHO guidelines of strict breastfeeding for 6 months, whereas in the US it's 4 to 6 months. Again, the effects on egg and peanut have limited clinical evidence based on the numbers needed to treat being much higher. And compliance is going to be a big issue trying to get them in. And I think trying to get parents to introduce all these foods in before 6 months of age is going to make this a more medicalized process than a natural introduction of complementary foods, and make it more stressful for families when we're trying to decrease the stress of introduction of foods. And again, what was the role of breastfeeding on the results? I'm not going to go through this in great detail. These are the 5 studies that have been done with egg, 4 of which were done in Australia, and 1 of which was done here in Asia and Japan. You notice there's been no study in the United States that has been done, although I hear there may be some started in the next year or so. The interesting thing was the definitions of risk here in these populations were different. So high risk, again, based in the STAR study, which was the first trial. High risk was moderate to severe eczema. Then what we're called intermediate risk in the next 2 trials, having atopic moms or infants with a first degree relative in the next 2 trials. Where in the German study, it was having a normal risk population, so they did not recruit for a higher risk population. Again, in the Japanese study, which was one of the only ones that really worked, was looking at having atopic dermatitis and concomitant treatment of atopic dermatitis while introducing or not introducing egg. The other big difference is the type of egg that was introduced in these studies. In these first 4 studies, it was raw egg. It was heat pasteurized, but it was still raw egg, which is going to be more allergenic, whereas heated egg, when you heat it up, either in baked form or cooked form, it does denature some of the properties of egg, making it less allergenic, which is maybe some degree why it worked as well in the Japanese study. They started with a very small amount, 50 milligrams of heated egg for the first 6 to 9 months, from 6 to 9 months, and then from 9 to 12 months increased it to 250 milligrams of heated egg, which is probably what we recommend in the US and what we're looking at in our guidelines. Starting with a baked egg product, if they tolerate that, then they could go on later on when they're older to maybe try scrambled egg, but trying scrambled egg in a 4 to 6 month old, again with a consistency issue, this has to be a logical introduction for these families. Introducing peanut for 4 to 6 month old or fish for a 4 to 6 month old may not work very well. You have to find other ways to introduce it, and many infants may not tolerate fish till they're on the stage of eating meats and things like that. But at least with the Japanese study, there was significant difference in the egg allergy and the ones that received it early versus that in the placebo group, so much so that the trial was stopped early because of the effect. The only other thing I'll mention is with the German study, they used about 2.5 grams of raw egg protein, which is quite a bit, and they did see a high rate of anaphylaxis with that amount being introduced. So again, I think starting with a much smaller amount of a heated product is likely to be safe and maybe more effective with getting those in. When you look at the meta-analysis that was done, looking at the different studies, so looking at the 5 randomized controlled trials with egg as well as the EAT trial, the overwhelming effect was that introducing egg early does seem to prevent egg allergy. Peanut, the primary effect was with the LEAP study by DeToy versus over the effect of the EAT trial. But again, looking at, there was moderate certainty evidence for both peanut and egg to say that there's a protected benefit for introducing egg and peanut early. Turning now to atopic dermatitis, because again, the LEAP trial was one of the first ones that said high risk is defined as having moderate severe atopic dermatitis. And the rationale was, when you look at the protocol online, that estimated that children that had some reaction to milk, egg, or both, in a positive skin test result, they were with moderate severe atopic dermatitis were at high risk of developing peanut allergy. Again, I don't know why milk should be considered different than egg. Again, they mention it here, and we were right. Talking about the guidelines, we considered that milk should be one of those risk factors, as well as having a sibling having peanut allergy, but again, it was decided to use the strict criteria for our peanut guidelines just with that. But when you look closely at the data, we reanalyzed some of the data that Matt Greenhot at our group in Colorado. Reanalyzed the data. It's a free download for you on their website. And what it shows here is looking at, on the x-axis was the SCORAD and the increasing SCORAD number versus the timing, the risk of developing peanut allergy. What you see in the red line is the early introduction group. So when you look, primarily what the effect was, if you introduce it early, regardless of what your SCORAD was, even if you had high numbers of severe eczema, really the introduction early was the most important point. Whereas if you didn't introduce it, again, you see the effect that if you don't introduce it, as your SCORAD increases, you have a higher risk of having peanut allergy. But it seemed to be that the eczema severity really played no role, or not as much a role in the patients that introduced it early. So it brings up the question, does atopic dermatitis cause food allergy? And this was the meta-analysis that was attempted, but more systematic review because the quality and difference of these studies could not allow for a meta-analysis. But when 66 studies, that you start to see the effect that atopic dermatitis does increase your risk possibly of having food allergy, but again, it depends on how you define who diagnoses the atopic dermatitis, as well as how food allergy is diagnosed by food challenge or not. There was some association with a more severe atopic dermatitis phenotype, and also some studies showing that the earlier onset of atopic dermatitis may also play a role. But what if we could identify patients at risk early on in life that may be a higher risk for atopic dermatitis with something as simple as measuring transepidermal water loss in these infants? This is a device that costs about $1,000 right now. It's very safe to use, very quick to use, and can be used on infants within the first few days of them being born. And here they're looking at the highest quartile of transepidermal water loss, in addition to looking at filagra mutations and family history of having allergic disease. And they found that the odds ratio of having food allergy at 2 years of life with the day 2 transepidermal water loss in the top quartile was 18.7. So within the first few days of life, you may be able to identify patients at the highest risk of developing atopic dermatitis. And this goes into another simple study that could be done in intervention, actually, that can you prevent atopic dermatitis and then possibly prevent food allergy. And this was looking at about 120 infants at high risk for atopic dermatitis based on a parent or sibling with AD, either using emulsion-type moisturizer or using a petroleum jelly. They wouldn't let the group in the non-intervention group not do any kind of intervention, so they used petroleum jelly. But you can see the amount of petroleum jelly was much less used on a daily basis compared to the emulsion-type moisturizer. And what they found is that if you use the moisturizer starting from week 1 through week 32, you actually can prevent the onset of the development of atopic dermatitis. So again, a very simple intervention that can be done early on, especially if you can identify ones that are higher risk. So what do the guidelines say? Hong Kong guidelines, right now, again, no unnecessary diet restriction during pregnancy or lactation, consistent with what I said before. Breastfeeding for the first 6 months, consider hydrolyzed formula, and introduce complementary foods early on. The UK just came out with the Food Standards Agency recommendations, again, looking at primarily peanut and hen's egg based on the studies that have been done, but they should not be considered any differently and should be introduced along with breastfeeding and other major allergens. Their guidelines do go into looking at evaluation before, possibly with patients that have a history of severe eczema or a suspected food allergy, consistently what I talked about, whereas it's really the Australians and New Zealand that have been introducing peanut and major allergens early on without any screening that say you really do not need to do any specific screening for these, even with peanut, even though the rates of peanut and egg allergy are much higher in Australia. But all infants should be given basically all major allergens. You shouldn't distinguish them differently from any of the other ones, and they should be started around 4 to 6 months of age. And finally, looking at the APA-PARI consensus statement that was just published this year. Again, introduction of foods around 6 months of age, and peanut in countries where there's a high prevalence of peanut allergy. So again, when we write these guidelines, peanut is going to be much more important for us in the United States compared to egg and some other foods, shellfish, and other countries in Asia. And this table kind of shows that. Whereas egg is the primary one in Chongqing, China, whereas shellfish is much higher. Well, we don't have a shellfish allergy, nearly about a quarter of that, but our rate of peanut allergy is about 2% compared to in Hong Kong about 0.5%. So for us to tell you to introduce peanut allergy early, as opposed to introducing possibly shellfish and egg, probably doesn't make as much sense compared to what we have in the US. And again, you see different regional things. So I think these guidelines have to be set towards what the common allergens are in everybody's respective country. I'm going to end with the roles of a diverse diet and a healthy diet. And again, as Mimi and Gary hinted on some of this, and I'm also going to promote the dietitian because I think they played a big role actually in LEAP that really was not really talked about as much. But the idea is that the increasing number of foods and diversity of foods may play a role on your risk of developing allergic disease. And Dr. Venter, who's now with our group in Denver as well, is actually working with Yaki on a task force to actually identify a diversity score that can be used. But what's been seen in observational studies are as you increase the number of foods and the diversity of foods that you introduce in the diet, your odds of developing asthma or food allergy decrease as the number of foods increases. And if you look at the impact of peanut consumption in LEAP study from the dietitian standpoint, really the patients that were had early introduction to peanut had much more exposure to dietitians to make sure that they were introducing it and keeping it in their diet. But the dietitians also talked with these families about introducing other foods, healthy foods, foods that were cooked at home, fruits and vegetables, along that line. So the fact that these introducing LEAP to everyone without having some of that dietary intervention may not work as well. So the ones that were randomized to consumption because of their dietitian exposure ate less just chips and crisp and fried foods and processed foods, ate more, like I said, fruits and vegetables and foods prepared at home. So again, diversity of diet because of what their exposure was to the dietitian may have played a role in LEAP as well. And this is an interesting paper done by Pete Smith looking at what we call the advanced glycation end products, which the Western diet unfortunately has a high number of these because of what we eat with fast foods and fried foods and things. So, and we know that diet is high in these ages and age-forming sugars, the child may have more allergic response and that increased risk for developing allergic disease. So again, if you have some dietitian that can help talk to families about eating a healthier diet, a more diverse diet, with fresh fruits and vegetables, you may actually decrease your risk of developing allergies as well. So we'll just summarize kind of what we talked about, looking at prenatal factors, perinatal factors, and postnatal factors, and what can you tell families to do to possibly decrease your risk of developing food allergy. So having moms eat a diverse diet is important, as well as having the infant eat a diverse diet. Having babies born by vaginal delivery is something to consider. I know we talked about it, one of our dinners here last night, there's more C-sections, there's rising C-sections here, and Asia has also been in countries in the US as well. And if you're not born by C-section, could you do the vaginal seeding by taking a swab of the vaginal cavity and swabbing the patient's, the infant's mouth. Breastfeed for a variety of benefits has been talked about in multiple lectures. Start using a moisturizer on your baby daily within the first few days, even if there's not high risk, but if you could identify patients by a simple probe looking for transepidermal water loss, you would have more patients that may be higher risk that you would want to really tell families to do that at a higher rate. And again, I think introducing a variety of healthy, diverse foods, including all the major allergens, starting around 6 months of age. I think there's a range between 6 and 11 months that can be done, but trying to get all major allergens at least done within the first year is probably important. And again, it needs to be based on a logical progression of those foods, starting with peanut or with fish or sesame, things like that is going to be harder to do, but starting with milk can either be in yogurt form rather than whole milk until after age 1, egg possibly in the baked form first, and then getting to fish and other shellfish and things when those infants are tolerating solid foods like the meat stages. But again, it needs to be tailored to what country and what your ethnic practices are with introducing those foods. And with that, I'll end. Thank you.
Thank you very much, Professor Fleischer. May I ask you one question,
Sure.
Professor Fleischer?
Sure.
You were saying that there is no conclusive evidence of whatever you do for the pregnant mother. Is that right?
Well, as far as avoiding foods like major allergens, so they did studies earlier on, 15, 20 years ago, looking at avoiding major allergens like milk and egg and peanuts and tree nuts, the mother avoiding it, and whether it had an impact on the infant developing allergy. And those didn't seem to show an effect, and actually have had some negative impact on the child's birth weight in the mother's diet. So that's really what I mean. I think there's a lot that needs to be done looking at prenatal factors of the mother's diet, and one of the things that Korean Inventor is working on in our hospital on a grant is actually looking at what maternal factors you can modify possibly, because I think we focus so much on afterbirth that we really haven't focused on what you can do in the mother's diet or mother's risk factors to decrease those things. So I think it's an area that's ripe for research now that needs to be done because we don't really know very much.
Oh, thank you very much, because I thought those studies were not very big.
No, they're very
Yes.
small. I mean, that's where a lot of these,
Yes.
the data that when they came up with these recommendations in 2000 were very small numbers.
Yes,
I mean, you're
very
talking
small.
100, 125
Yes.
patients. So it's amazing that those, at that point, recommendations were changed based on that. And again, it says less than 10 years later, they really said, look, this really is not the impact it was supposed to have and may have played a role in worsening things. But when you look at the rise in food allergy over the last 20 years or so, the rise was happening before the timing of introduction, really, those recommendations. So I think it may play one part of it. But
Yes.
again, there's a lot of factors that go into prevention. It's not going to be one thing, microbiome. It's not going to be timing, diversity. Hopefully we can figure out conglomerate things that can be done that's simple enough to do, because if we make it too complicated, then it's not going to get done either. So
Yes. Maybe would you be considering doing something like that for pregnant women? Yes?
Sorry, I have to space out.
We were talking about doing some preventive studies in the pregnant women rather than after birth, in babies after birth.
I think that's really important. Yeah, I can't agree with David more. I think that, the literature, especially around immune development, and now our understanding of the importance of the mother's microbiota in the infant's microbiota, and also succession planning in terms of diet effects. I think the maternal, both before and during pregnancy, is an optimal time to consider manipulating their health. And there's many opportunities, both from their diet, their activity levels, manipulating the microbiome, their immune responses would be important. I think, David, I don't know if you're aware, but wasn't Susan pulling something together in Flame, trying to create a multi-centre sort of approach, multi-centre trial looking at a multifactorial approach for maternal intervention? We're running one of our PhD students is looking at maternal diet and whether that has an impact on their microbiome, the infant's microbiome, or infant immune responses later on. So that'll be interesting.
I think it's a big piece of the puzzle that hasn't really been investigated very well. So
In Chinese tradition, we're instructed not to take shellfish, not to take snake, and a number of other things when we're pregnant. So there must be some wisdom in that experience.
possibly, but then the rates of shellfish allergy are higher, so does it play a role? It's hard to say, but yeah. No, I think, well, then it's the same in the U.S. You're not supposed to have certain fish, raw fish, sushi, things like that, because again, there's different things you can cause infection. So, but